Hi, I'm here with Esen Akpek of Johns Hopkins Eye Institute. I'm really excited I just heard your talk about Sjogren's syndrome, and I'm wondering if you could share with us some of the myths that ophthalmologists and the general public may have about Sjogren's.
Sjogren's is a very common chronic progressive autoimmune disease. It's probably the most common autoimmune disease in general population. An estimated 4 million people in the United States are affected by it. The most important thing about Sjogren's is that even though it affects the rest of the body, not just dry eye, dry mouth, it's very under-recognized, underappreciated, and undertreated.
And what if we miss the diagnosis, what is the consequence for the patient? What are we also missing systemically that if we could catch it in the first 4 years of their presentation?
Well, this is very important aspect of the disease. These patients usually start with dry eye and dry mouth symptoms. It takes on average 10 years before the patient comes in with a significant extraglandular ocular finding, such as corneal perforation, sterile corneal ulcers, or infiltrates, scleritis, episcleritis, optic neuritis. And usually it takes about 6.5 years between the onset of symptoms and diagnosis of Sjogren's syndrome. What happens is that after the first 4 years of disease progression, it gets more significant. The risk of lymphoma and developing extraglandular systemic findings such as liver, lung, kidney involvement increases considerably without the treatment. So early diagnosis is very, very important.
So if I am seeing a patient and I'm concerned about Sjogren's, walk me through what I should be doing.
Okay, well, this is also a very important question. So we, as ophthalmologists, should have the number one question in our minds whenever we see a dry eye patient. Is this the patient with underlying Sjogren's syndrome? For example, in the field of scleritis or uveitis, it's very common that a doctor will see a patient and do an autoimmune workup to identify an underlying disease. But in the field of dry eye, this isn't like that. So whenever we see a patient with dry eye complaints, the first question that should come to mind is that, is this the patient with Sjogren's syndrome? Because 1 in 10 patients with clinically significant dry eye will have an underlying Sjogren's. So we have certain things that we consider before we test a patient. 1, clinically significant dry eye, meaning ocular surface staining and low shimmer. And also, we need to ask the patient whether they have fatigue, joint pains, family history of autoimmune diseases, and dry mouth. If the patient has those things, they need to be tested. Testing includes serological testing and biopsy. Serological testing is positive in about 60% of the cases. A biopsy might be necessary in the rest, meaning almost half of the patients.
And tell me, I've been including osmolarity in my workups of my dry eye patients now. How do you see that in this workup of a Sjogren's patient, and do you see in the future that it may play a larger role?
I think so. So the usual dry eye workup should always include Schirmer's test without anesthesia, ocular surface staining, meaning lissamine green staining of the conjunctiva and fluorescein staining of the cornea, and also tear film breakup time. Osmolarity is a newer test. There's also the inflammatory, which measures MMP9 levels in the tear film. Those two are newer testings. We don't yet have good clinical data in regards to differentiating dry eye, Sjogren's related dry eye from non-Sjogren's. Those two tests correlate with the severity of the disease, and the more severe the disease is, meaning dry eye, the more likely that the patient will have an underlying Sjogren's syndrome. So those tests, along with the other clinical tests, are very important.
Thank you for spending this time with us. It's really important disease for us to keep on top of and understand, and I appreciate your time.
Thank you very much for the opportunity.